We are hearing a lot about multidisciplinary care and implementing this practically in patients who are older who have cancer. You're presenting on this and you talk about the challenges and the pitfalls. Briefly, what are the challenges and the pitfalls of looking after older patients?
There is a lot of challenges and pitfalls to implement a multidisciplinary team in geriatric oncology. That's why we are dealing with different people from different areas with different expectations. And this is a hard task, and this is our challenge, to deal with these expectations and try to find a common language to achieve a common goal for our patients.
What sort of things can go wrong?
And the communications, I think we must establish good communications between geriatricians, between the oncologists, between the patients and all geriatric team, and pharmacists, and nurses, and everybody. The communications, I think, is the key about your team, the well done about our team.
Right, now you've done a study on this. You looked at breast cancer in older patients. What did you do?
I provided a longitudinal evaluation in patients, in elderly patients with breast cancer. 5 CGA geriatric evaluations was done in 2 years. And we want to see if the oncologic treatment, the plan of the oncologic treatment changed. And in our study, 45% of the plan changed of these patients. And the care, the longitudinal care was very important to this change, you know.
Right, so you did comprehensive geriatric assessment.
Yes.
More than once, you repeated it and you changed. What kinds of things did you change as a result of the evolving results of your CGA?
Yes, we changed some patients who must receive chemotherapy, we changed, and the patients the adjuvance was not done, and sometimes patients we have patients who have a Down syndrome, and they realize that we can't do nothing about these patients, and so we implemented the treatment, and we agree with the oncologists, no, we must do the treatment, we guarantee the quality of life of these patients. And sometimes the oncologists or the surgeon thinks that the patients could not receive the treatment, and we recommend that no, she can receive the treatment, she will be able to tolerate this treatment, and this will be best for her in quality of life, in terms of quality of life. And in other kinds of patients, chemotherapy was not done, and surgical, all the patients who deserve to receive the surgical treatment, they receive the treatment. There is no change in this, but chemotherapy, the hormonal therapy changed, and the radiotherapy changed too.
So you can improve quality of life then by not giving some of the treatments which would have been given. How big was that improvement in quality of life?
We have that 45% of the patients, we changed the treatment, you know, and we didn't evaluate the quality of life properly, you know, but we have that 9% of the patients have some kind of geriatric changes in this longitudinal care, geriatric interventions who improved their quality of life.
What are the practical implications of this for doctors caring for their patients?
I realized that the importance of the communications between the team, and for comprehensive geriatric assessment make a good job, make what they propose to do, we must communicate, not just do the questionnaires and not having arguing and discussing what we are caring about our patients. We must talking about all the time with the team and with the oncologist and the surgeon. And this is what the most important thing to improve the quality of life of this care.
So you're saying that it's necessary to do comprehensive geriatric assessment and to repeat it.
Yes, I really think that is important to repeat, not just one time. We start to do this comprehensive geriatric assessment when the patient was diagnosed by the cancer, and we did the first evaluation. And so along of the treatment, we repeat to see what's going on with these patients. And this is very important, not just at the first time, to seeing these patients providing a longitudinal care and getting interventions who could benefit the treatment and the patients.